Okay, but it didn't like my advancing, so let me try it with there. That will work. Um, so what I'd like to do today is talk about how values have shaped goals, questions, and methods in reproductive health research. And I want to suggest that we have witnessed, or I hope are witnessing, a continuing arc toward reproductive justice. Um, it is not sure, it is not linear, but I hope it's moving in that direction. The outline of the talk that I'll share is to go back in time a bit and talk about 20th century research ethics, the origins of the rules, regulations, but also, and more importantly, I think the underlying ethics that grounds our research. Then I want to talk a bit about women and reproductive health and research, where I think that those are distinct, yet there is overlapping neglect of both women's health and reproductive health, and obviously those can overlap. And I want to conclude by talking about changing values and evolving research methods. And I know at the end of my talk today, you'll be talking about one of those methods still more. I'd like to acknowledge the tremendous help of Shade Tikaru, who has been in my research ethics class this term and who chose a topic near to my heart and near to the heart of Embrace. And so I want to acknowledge that I've been influenced by what she presented, in fact, yesterday, as well as these two articles that I've posted here as references for my comments. So there's obviously a huge literature on which I'm drawing, and a fairly long history. I'm going to begin talking about that history with the Nazi human experiments, the trial of the doctors who were involved in experimentation on at least 15,754 people in the 1940s. And a reason that I think this particular abuse, atrocity, violation of human rights, particular set of human human participants, they weren't participants, that's where we get the subjects, they were really subjected to and experimentation. And the reason this is so key is, as you all probably know, is that it gave us, really the world, the first articulation of ethical points that must be the ingredients of ethical research. So voluntary participation, that there must be no undue pressure to participate, that people must give their informed consent, must be allowed to, and without it, you can't do research. This is different from our clinical care context, where informed consent is important before there's a violation of bodily integrity or before one undertakes a therapeutic intervention. But there, informed consent is part of shared decision-making in the service of a patient's plan, their life plan, their hope for their health. In the research context, I think of informed consent as the last opportunity, the provision of a final opportunity to say no. So that's why it's been such a formative doctrine in research ethics. Other ingredients, of course, is we need to have scientifically valid methods of research that should lead to results, if all goes well, that are socially valuable. We minimize risk, avoid unnecessary harm and suffering. People have the right to withdraw from a study, and researchers have an obligation to stop the experiment or the study if injury or death is likely. Those were the key points that came out of the trial that were the legal opinions that became known as the Nuremberg Code. And then I want to talk, not a whole lot because you've recently had an opportunity to hear more about it, but during this time, the Tuskegee syphilis study of untreated syphilis in the Negro male was ongoing from 1932 to 1972 and stopped when there was an expose in the news about it. So this is just a plea for the importance of eyes on pretty much everything that we all do, that we should be open to the scrutiny of a press, the newspapers and news reporters operating with integrity. And so, go out and subscribe, please. It's important to keep these checks in place. But interestingly, it was, 30 more years before the United States began to really codify those principles that came out of the Nazi experiments and the Nuremberg Code. And so we had the National Commission or the President's Commission for the Protection of Human Subjects in Biomedical and Behavioral Research. And that commission eventually drafted the Belmont Report. And I'll go mention the three principles that they detailed of respect for persons, of beneficence or the need to seek to do good and to minimize harms to research participants, and justice. And they applied those principles in three key areas that those of us in research are all quite familiar with. Respect for persons in the context of informed consent, and I would say the protection of welfare by giving that last final right of refusal to the individual. The evaluation of risks and benefits, and then justice, fairness in the selection of participants, so that no longer could researchers simply say that, well, this is a population that's convenient to study. There has to be a very thoughtful justification for the inclusion of people in research or for the exclusion of people. And that really takes us then toward the latter part of the 20th century, when there began to be more of a focus on why we should not exclude people from research. So in the 1980s, as we know, the US witnessed the beginning of the AIDS epidemic. There was a gradual transition during the 1980s from thinking of this new illness as gay-related immune deficiency to autoimmune deficiency syndrome, and then the discovery of the virus that was causing AIDS. And throughout this time, there began to be some questioning among women about the degree to which what research was going on applied to them. To what extent did HIV/AIDS research focus on their health concerns? And that's a mixed story. In part, the responses from at least those in our federal government was that, well, we don't have as many studies, or we don't have the funds to fund all of the studies we need to, and there are fewer women with HIV/AIDS, so we'll put our resources where there are the largest numbers affected. There was also a curious kind of twist on the idea or the argument that some women activists were putting forward, saying that, wait a minute, you have this requirement of fair subject selection for your studies. and we're being excluded. These are men-only studies in general. And a response was that, well, but that's not really unfair because women weren't being excluded from anything of value. This was research. We didn't know what was going to work. We didn't know that participation would be beneficial. So it's not unfair to exclude someone from that opportunity. So eventually there was argument of, but wait, we don't know how the drugs that are eventually developed are going to work, whether they'll work in women. We don't know, well, the course of the illness in female bodies. So there was this tension about fairness, benefits, whether research was beneficial. And this really was a time, well, it was past the time, right? Just the 40s saw penicillin. And really, the 20th century was a time when medicine began to be able to do things for people, and where there was a prospect of, if you were involved in research, that it could actually have a health-related benefit for you. We're getting good at it. So now it was more of an opportunity. So by the 1990s, we were seeing in our research ethics frameworks a move from protecting people to including people for social benefit of more generalizable results of research, and potentially for their own benefit if participation yielded results that applied to them and that they would be first in line for. My dog in the background is being first in line for something. I think he finished his lunch. Interestingly, breast cancer advocates took a page from AIDS activists. And so there was a shift during the same time from merely creating awareness of breast cancer to real activism, lobbying in Congress that yielded the Department of Defense breast cancer research program, as well as other breast cancer focused research. But what's significant about this, from my perspective, is it's this desire on the part of people most affected by the disease, AIDS, breast cancer, cancer in general, whatever, to be activists, to be wanting into research rather than being protected from it. The Women's Health Initiative was created in 1991 within the NIH. It was a turning back from the days when the FDA and indeed most research bodies excluded women with childbearing potential from clinical trials, ostensibly to protect them and their fetuses. By 1987, the NIH was requiring a justification be provided for the exclusion of women. But there wasn't as much enforcement of that as would be desirable. So it wasn't until 1993 that there was actual law and regulation requiring inclusion of women and minorities in clinical trials, and also requiring that trials be constructed in a way that you could analyze different effects of the variables being studied, the research questions, what effects those would have on women and minorities. So you had to have the statistical power to be able to do that analysis, and that meant needing to enroll a sufficient number of different populations, women and minority populations, in the research. So during this time, we got what we now call the Common Rule, this a part of our Code of Federal Regulations. I'll say just a bit more about that in a moment. But we also saw the California Breast Cancer Research Program that actually required their researchers to use community-based participatory research methods. And I think that's significant for thinking about just the evolution of research, because to many of us, I think, community engaged research, community based participatory research feels still fairly new and innovative. Um, but it has a history. So why were women excluded? And this is probably familiar to many. There was a sense that human physiology is male physiology. I will have time to tell one small anecdote, and that is I finally called into my first radio program, and I think it was 1A or on point something. There was a discussion about, I guess the Vikings are now going to have male cheerleaders as well as female cheerleaders, men as well as women. And this is just, I guess, traumatic for some fans. And there was one person, one speaker from the Viking perspective, a fan or maybe an official, saying, well, it's just because people are making this all about gender and they're taking the masculinity out of it. Well, what is masculinity but not gender? That was my only one line that I called in with. But that's a reflection of this notion that, well, to be human is to be male, and everything else is an exception that we see in so many aspects of our life, including the very important ones like football, cheerleading. But there was also this assumption that, well, on the one hand, there are no important differences between male and female bodies. So, what we learn in male bodies can be applied to females. But at the same time, female bodies are also too different, so that to include them would introduce expensive complexities like, hormones and pregnancy, because we know that, men don't have any hormones. That was ironic, sarcastic. There was also a theme and an important one of that including potentially pregnant people in research presents risks not only to them, but to fetuses. There was concern for protecting innocent, non-consenting future children, and that's a priority. At the same time, ensuring that scientific discoveries would apply to female bodies was not a priority. And remarkably, given the interest in protecting future children and fetuses, fetal protection, research on reproduction has not been much of a priority. So I was interested in, well, a body of literature, but this is one example that demonstrates the need for more research into reproductive health and disease. So if we do think that reproductive health is important, if we're concerned about, if we even have currently thought of a pronatalist perspective, then there's need for research on reproductive health and disease. And that would be in part because, let's see if I can I don't know, does this move? Because the average number of articles on non-reproductive organs from the period of 1966 to 2021 was 4.5 times higher than the number on reproductive organs. So just a lot more research on listed here. Now, many of us would also say the brain is a sexually involved and thus reproductive organ, but we understand the categorization. Breast and prostate received the most research attention among reproductive organs, but largely due to the amount of cancer research being done on them. this graph shows, well, the diagonal blue line corresponds to where an equal number of disease-related and non-disease-related articles would fall. So if all of the circles fell along that line, there would be an even number of disease-related, non-disease-related articles related to each organ. Shows that many reproductive organs have a good balance of disease and non-disease related research, but overall receive much less attention than those outside of the area of reproduction. And the lack of non-disease research may, of course, impede diagnosis and treatment of reproductive health conditions that we care about. Preeclampsia, miscarriage, all endometriosis. All of the conditions need some basic science to ground future interventions. So this graph, and I'm hoping you can see the far side where shows that from 1966 to 2001, only breast and prostate saw increase in the number of articles published at a similar rate to the non-reproductive organ of the kidney, which was itself the second to the bottom of the non-reproductive organ study. So still not a huge increase. The least studied organ of the intestine had a similar publication rate, those of the other five reproductive organs. So again, very little. And the authors of this paper observed that while the placenta and the uterus are widely viewed as causal organs for reproductive complications that claim large numbers of maternal and neonatal lives, and treatments cost tens of billions of US dollars every year, there is relatively little disease-related research into these organs. So the graph B shows the number of publications for each of those 14 organs adjusted by omitting those studies that referred to cancer, that had cancer as a keyword. And omitting those the cancer-focused articles had little effect on the number of articles of non-reproductive organs, except for lung cancer being prominent. But it had a large impact on breast and prostate. So again, that's concern for cancer was one reason, perhaps the primary reason, that there was that focus on those two areas of health, organs of health. The authors also found the number of funded research projects in non-reproductive organs was higher than the numbers for reproductive by a factor of 6 to 7 times. And the dollar amounts per project were somewhat similar. They also noted that the NIH institute that most supported reproductive research, which is NICHD, doesn't have reproduction in its name, is one of the lowest funded institutes. It's significant, I think, that and to the extent that there's a reproduction focus, that it has a lot to do with, or is under the umbrella of child health and development, not necessarily maternal, women's, or the health of pregnancies and pregnant people. So why has research on reproduction not been a priority? And I think my view is that this is because cultural values and scientific values coincide in this domain. That the stigma and the taboos surrounding sex and reproduction, miscarriage, abortion, breastfeeding, women's sexuality, in particular sexuality that might result in pregnancy, or where pregnancy and reproduction is in the in the cards, uh, beginning with desire and moving forward, all is quite taboo. At the same time, medical scientific focus is on disease, not really on health. Fun fact that I only learned this year. I don't know where I was, but I only learned like September, that at the University of Pittsburgh, exercise science is in the School of Education. It's not in the School of Health and Rehab Sciences, not in public health, not in medicine. Yet, if you read just the opening blurb for that department, it's clear that what that department's focus is health, flourishing, human flourishing, exercise, nutrition, so on. So part of the problem, I would suggest, is that while an ounce of prevention may be worth a pound of cure, prevention isn't as profitable. And it doesn't lend itself to the kind of industries that we have had. So, pharmaceutical industries, medical device industries, interventions. Um, and people in general, maybe I might contend North Americans or Americans in particular, are practical and like to fix things, like to take credit for fixing things. And so understanding what works and how it works is basic science. And we know that society, and especially Congress, does not want to fund research that leads to basic understanding, but instead wants to fund interventions and problems. The whole mapping of the human genome, kind of one of in my lifetime, one of the most uh, far from intervention, uh, huge scientific projects, was nevertheless sold to the public and sold to Congress for funding as delivering interventions in the genome that would prevent disease and lead to being able to edit genes and treat disease, 5 years, 10. Another reason that there's already hinted at that there's been less research in reproductive health does have to do with the notion codified in the common rule when we finally took all of our research ethics frameworks and values and put it into law. The regulations that are enforced by institutional review boards, for example, created categories of vulnerable research populations that included pregnant women. And so until 2018, pregnant women, and by extension, potentially pregnant women, were considered to be a vulnerable population, to be whose inclusion might need to be justified, or at least needed to be treated very carefully, despite decades earlier than 2018, the NIH saying that you had to justify their exclusion. Again, that still wasn't particularly well enforced. So following 2018, our law does refocus attention on children, those with impaired decision-making capacity, those who cannot consent, and by extension, yes, protection of fetuses remains important. And one feature of the fetal protection framework that we've needed to wrestle with is whether we mean a kind of a zero tolerance for risk to fetuses approach. And in many cases in research, that seems to have been the case, and it may be expanding into other domains as we see today. Situationally vulnerable individuals were also identified, or groups of individuals, employees, military members, institutionalized individuals, and so on. So to combat this lack of attention to reproductive health, we have a number of things. It's kind of odd, perhaps, to even be talking about this with a group that's focused on reproductive, maternal, and child health. But I think from an ethical perspective, to kind of make the case for this research, we need to be mindful of this past. That we've moved from a focus solely on consent and respect for persons' autonomy and their decision making and protection of their welfare to also value fairness and inclusion, so that if you have someone who is consenting to participate and is willing to risk welfare or even the welfare of a future person, fetus, that fairness may indeed demand the inclusion of that person in a research study, assuming he or she meets the other inclusion criteria. So we moved to recognizing as well, when we instead of talking about mentally disabled people, people with perhaps psychiatric conditions, we now, following 2018, focus on their decision-making capacity, no matter what their mental health condition might be. And so there's a shift as well to thinking about conditions of people, circumstances of people in relation to research participation and consent, rather than labels of people. And so while those who lack decision-making capacity or who are subject to coercion, like soldiers or prisoners, may indeed need, I think, do need to be protected from being potentially taken advantage of and enrolled in research. That's different from people who are educationally or economically disadvantaged, for example. Instead of protecting such participants, it behooves us as a society, and to the extent that we can argue for it as researchers, to address the sources of vulnerability, the background conditions that might make us question whether their participation is voluntary, is in their interests as they define their interests, or whether it's perhaps from desperation. We recognize now, I think, that preventing pregnant people or potentially pregnant people from enrolling in research is not the only or the best way to protect future children, fetuses. Instead, we recognize we need to consider the well-being and health needs of women in their own right, and also the effect that their physical and mental health has on the children for whom they care, about whom they care. We also, in addition to that kind of shift from protection to more inclusion, we also have a series of methods that have been around for a good while of engaging with community members to gather, to glean their participation and the participation of their members in research. So this wonderful article that Sade exposed me to talks about the need for researchers to address maternal morbidity and mortality in Black populations because of the great need, but that in doing so, we or they need to mitigate harm of historical trauma Black people have experienced in research and in healthcare settings. And to recognize, of course, that not everyone recognizes the difference between clinical care and, say, clinical research or other research. It may all feel very much the same. And disrespectful treatment in a healthcare setting is part of the legacy that people in general, and Black people in particular, may bring to a research encounter. That to address maternal morbidity and mortality, we need to include not only Black pregnant people, but also their perspectives, their priorities, and their voices, and need to include them explicitly, systematically, transparently, and very visibly as setting an example and staking a position about what's important. So not only including people to be able to have representative, generalizable research results, have their representation so that there are generalizable research results, but to include their perspectives, priorities, and voices in constructing the research. So the authors and Sade and cited the Black Mamas Matter Alliance, which I summarize here what I take to be or take away from their advocacy in terms of creating a framework for thinking about the ethics of reproductive health research. So that it's important to recognize the positive and the negative experience and the expertise of participants and their people, the people who surround them, their elders, their leaders, families. Recognize it and really listen to it. We often, at least in philosophy and ethics, will say, well, you need to attend to this idea. You need to attend to this. Well, what does that mean? Well, at the very least, it means listening to the people who have the problem or have the expertise or the experience to share. Identify and confront and protect participants from patriarchal and racist assumptions, structures, and interactions. In part, by treating everyone with respect, recognizing their inherent worth as well as the value of their contribution to research. To be honest and trustworthy, empowering participants through developing their health literacy, their understanding of research and its processes, understanding the time that it takes, understanding its fits and starts and its false starts and its overturning of what we thought we knew by better information in the future. That we want to afford material benefit through the research interaction. Not so much benefit that we're unduly pressuring people to participate, but that people should really be able to benefit from their interaction with research systems. And recognize that research outcomes are only valuable if their implementation within the healthcare system is accessible and at the same time providing access to the healthcare system does not, there should be a not there, does not ensure delivery of high quality and respectful care. We need to work on that as well. There are also, I think, some valuable changes coming in difficult times. Not only do we have initiatives like the Center of Excellence, Embrace, but we have things like the NICHD, the statement on their website that, check out emerging research on this vital but understudied organ, the placenta, the importance of placental health. And if we look at the 5-year plan that they put forward, it's something that I think what I've been describing would support and embrace to support reproductive health, and to do so in a way that supports both basic science research and the kind of applied, more intervention-oriented, community-based research. So thank you. And I've left some time. I hope that we can chat. So I'll stop sharing and start looking. So thank you.
Thank you so much. Thank you so much. I'm sure there is a lot rolling through our heads, especially if we were able to maintain and or draw back in our focus. There was a lot here, and we're so appreciative of the different areas that you touched on, as we think about ethics and some of the origins of why
Mhm.
they actually arose with some serious significant harms that were done.
Mhm.
And also acknowledging our wonderful Sade, our graduate student researcher, and some of the past seminars that we've really been able to gain from community. So I really appreciate that you wove that in. I think it's so vital that we do remember that community knows that there's so much wisdom. Yes, there's a pathway through education that we, get letters behind our name. But honestly, we go back to community knows, people know themselves that you are the expert in you. And I want to validate and highlight that you made that point and reiterated that point, because we have a lot of community members here who we need to, ensure that you all are empowered to bring your wisdom to the table. That's why Embrace is different. That's why the Improve initiative is different, and that your voice, your perspectives, and your presence matter. With that, we would love, excuse me, to open up um, reflection time, question and answer time, to all of you. So, someone asks, what do you see as the different value propositions between basic science research and more translational or clinical research?
Mhm. Different value propositions. So, I'm not sure I'm understanding value proposition correctly. I think they have somewhat different values because different scientific values, different goals, obviously. If someone wants to unmute and clarify or write in, that's okay too. But I guess one thing that was hoping to suggest is that people in general are impatient. We're bad at things that take a long time horizon. We're bad at things that we can't fix quickly. And so I have done a lot of my work in genomic research, ethics of genomic research, and have been struck time and again by the genomic turn in so much of our research. And genes and the genetic foundation of health and disease and development, absolutely critical. But the environmental factors and so on are also incredibly important. And I think we have put a whole lot more money and emphasis into the kind of glitzy genome than in the pollution that surrounds us. I've been struck that when we look at the gene environment interaction, we have tended to think of the environment in very individualistic terms because that's what we can intervene on. It's really hard to clean up, the lot next door, the old gas station that, bled into the soil or the air. But you sure can, blame somebody for smoking, for drinking, for stress, um, because we put that on the individual, not reduction of the climate. Um, Obesity, nutrition, and so on. These very individualized notions of environment. That's not what I grew up thinking of the environment as being. That's sort of like that's what I do. But and I obviously it has environmental inputs into my actions. But I'd like some help on those environmental inputs into my actions, not just a focus on my actions themselves. So I think this is a really long-winded way of saying that I think we tend to put our money for basic science into the things that we think we're going to be able to intervene on most easily in the future. And that's going to be individualized, and it's going to be the kind of, the genome, as opposed to this broad, complex, messy, culturally embedded thing of our environment or of the family structure of whatever it may be. That's what happens when I don't understand the question.
I
I
was
just,
gonna say that, Sydney, would you like to respond to that reflection?
Yeah, thank you. Sorry,
there you
I'm
are. All right.
calling in mobily. Hopefully you can hear me.
Yes.
Yeah, I really appreciate your answer. I'm working on my PhD in bioengineering, and one of the things we're trying to understand is who's most at risk for experiencing an injury during vaginal delivery. And so what you're saying here about it's hard to get funding for things that are not directly intervenable. It's hard to sort of, I think, mentally process the landscape that it takes to go from basic science to intervening on a clinical problem. And so I think my question comes from a place of recognizing that there are so many basic science questions that we don't know that can enhance human health, that are different from projects that are directly about changing human health.
Mhm.
And so that's something I am just curious about coming from an ethics standpoint is how can we answer the best basic biology questions while keeping in mind that these are human people in a complex sort of environment, and then that we don't like things that we can't fix, and we don't, so I'm coming from that place. But I think you answered my question very well.
Thank you. Thank you. And I mean, I'm struck by research ethics suffering from a similar problem. It focuses on problems. Its history came out of an atrocity. And so it's intervening on individuals to give informed consent, looking at individual, will this person benefit? Is this person being coerced or unduly pressured into participating? You can look at that as opposed to, I think, a more recent focus, and what I'd like to also advocate for is looking at, I mean, I don't believe that poverty coerces people, because I want people, no matter how poor, to still be recognized as having their autonomy, their decision-making capacity. But in very difficult circumstances, people will quite reasonably agree to do things, to enroll in a study, to hang out at a crummy hotel and be infected with the flu virus to see if that vaccine worked. They'll agree to that. Well, how do we address that? Informed consent doesn't help. Thinking about whether they're coerced or not, whether their participation is voluntary or not, doesn't really help. What we need to address is income and poverty, or so the underlying kind of background conditions. And so I think researchers, no matter whether they're working on the basic science problems or intervention research, it would be great for them to work together to articulate this need to address background conditions and how that follows through their research plan, and how their research agenda and plan follows through to a better vaginal delivery.
I again appreciate the conversation happening here. Something that is very different about Embrace is the intention and effort actions to include at all levels of Embrace the
Mhm.
community. And that's something I know that has, so it's just interesting because having been here before at the University of Pittsburgh, at a time when I was learning about Black researchers who wanted to include community. And it was, and I was literally told to go talk to some more seasoned researchers than myself because I would never get funded if I continued to push that. And if I continued to push that I didn't want to start with a diagnosis because, and I was doing mental health and child maltreatment research, but it was like, unless you have a diagnosis, you are not going to get funded by National Institute of Mental Health. And you know, and if you want to focus on Black populations, which have the highest, you know, incidence of many of these things, you're not going to get funded unless you have a counterpart that's white. So I went to Maryland and talked to two seasoned researchers, and it was that very thing. And so until um, NIH somehow started saying, okay, you need to do inclusion, which you talked about, that inclusion is a requirement. Then it was those white researchers who were funded for so many years, who had funding, who could then go say, okay, community, I want to partner with you. And what they would often do was ask those researchers who didn't get Black researchers who didn't get funded, well, who would you have partnered with? Who can I partner with? So they had that as a draw. But I
Yeah.
really see that we,
Mhm.
this thing that's going on with the Improve grants, if that could filter up and filter out
Mhm.
to the basic sciences, to
Mhm.
other types of clinical and translational research, that could change things because community does know, okay, to not coerce people in poverty but yet get them involved. How would we do that? Okay,
Yes.
yes, you're compensated for your research. They're going to be
Mhm.
involved in research. Compensate them for their knowledge and wisdom and experience and all that they bring, and help and have them help shift the focus or determine the research questions because there's a lot of different kinds of wisdom.
Yeah.
And so there
Yeah.
are ways.
Yeah.
It's
Oh, there
just
are. There
it's just
are.
that we have to give up some sense of control sometimes in some ways in order to get that change there. Other questions, comments, reflections?
If they're not, I'll add one more thing, but
Awesome.
because yeah, Sydney being from a bioengineering perspective, bioengineering is an area, and I'm working with some people there, more on the neuroprosthetic area, where they really want to get people involved all along the research pipeline to advise, collaborate, and not just about like how to make it more amenable for um, or more attractive for people to participate in, the clinical trial or the first in human experiment, but how to have people talk about, in this case, neuro sensations. So sensations, what is it like? And to advise non-human animal researchers about what's important so that non-human animal researchers don't go down this rabbit hole of something that isn't really going to be relevant for human health or isn't going to be adequate for human health. If what you want is to be able to grasp something, but they stopped at getting tingling because now it's no longer interesting. We figured out which nerves it are that give you tingling. It's like, well, but wait, it's not grabbing. So that kind of participation, I think, community-based participation or a version of it all along the research pipeline is something we're beginning to innovate with. And thus it means helping among people, outside of research and outside of academia, not just empowering with health literacy, but with research process literacy as well, so that they can really feel empowered to speak up, not just, kind of there and window dressing or something.
Well, not to stretch our team too thin, but if they're looking for people, take a snapshot of this for us, Dr. Lisa, and share it with them. We have
Absolutely.
some just brilliant minds, and as you were talking, Nadia came to mind where you mentioned, shared with us that brain.
Mhm.
Um, acronym
Mhm.
the speaker last week. You know,
Yes.
I thought about that's just a really important concept that could be spread up and down, up and down the research continuum. And so lots of good things happening. And I just want to thank you all, those who, again, we have to drown out the noise sometimes to come back to center. And I appreciate the presence that everyone had here. Dr. Lisa, we appreciate what you shared. And I think we continue the conversation. So thank
Thank you so
you.
much.
Thanks, everybody.
Enjoyed it. Everyone be well.
You too.
Happy New Year.